So today I'm going to dive into one of the most recently published trials that was actually discussed at one of the world's largest cardiology conferences in Amsterdam last weekend at the ESC. First of all, congratulations to the authors for conducting this trial as they put the spotlight on how we really need to be ultra careful in how we apply evidence from large randomized trials that included younger patients to those who are elderly and frail. The idea of doing this video actually came from Dr. John Mandrola from This Week in Cardiology after listening to his most recent ESC wrap-up podcast. So John, if you are listening and watching this video, please know that I am a huge fan of your podcast and have been sharing your work with the cardiologists that I work with. And thank you from the bottom of my apex for all the work that you do to help clinicians and doctors to practice as healthy skeptics and help us make better informed decisions for the patients that we care for. There's definitely a need to make critical appraisal more appealing, especially in a world where things are easily oversimplified, spun, or misinterpreted in trials and guidelines. You are one of the reasons why I decided to create this YouTube channel, and I can't thank you enough for giving me the courage through your podcast to speak more openly about my thoughts about some of these dubious findings in cardiology trials. And hopefully I'll be able to get a chance to meet you someday at a conference or something. So in today's video, I'm going to go into a bit of an overview of the Frail AF trial, and I'm going to share with you some of my thoughts and point out some interesting things that I noticed and what I ultimately sort of took away from this trial. Hopefully we can stir up some good conversation about this topic, as we all probably know somebody or have had a patient in the situation where we've needed to decide on a blood thinning strategy for an elderly frail person with atrial fibrillation. Hello again. In case you're new here, I'm Herb, the heart pharmacist from BC, Canada, where we dig deeper beneath the superficial cardiology literature and help you choose and use wisely. Today's video is going to be a little bit different in that I'm going to try to do this with as minimal video editing as possible for the sake of time. I literally just put my kids to bed, and so please try to bear with me as I feel like I still need to get this message out and some of my thoughts out. So let's just dive right in. So the Frail AF was a pragmatic, randomized, multi-centered open-label trial that included elderly patients 75 or older with a Groningen Frailty Indicator, or GFI, of greater than 3. They randomized patients already on vitamin K antagonists, either acinocumaril or fenprocuman, which we don't have in Canada, to either switching to a DOAC, either rivaroxaban, apixaban, edoxaban, or dabigatran, or continuing their vitamin K antagonist with an INR target between 2 to 3. Looking at their table 1 of their baseline characteristics, the mean age of the included participants were 83 years old with a GFI of 4, a CHA2DS2-VAS score of 4. About 2 to 2.5% also had concomitant antiplatelet therapy, which I'm not sure why. About 15% had a history of major bleeding, and close to 20% had some thromboembolic event previously as well. They excluded anybody who had valvular atrial fibrillation, defined as having severe mitral stenosis or a mechanical heart valve. They also included those with a body surface area indexed EGFR of less than 30. After randomization, it turned out that out of 7 of the participants, 5 of them actually did not have atrial fibrillation as per the thrombosis service that was following them. One of them actually had valvular AFib, and one of them also had a GFR of less than 30. They did include these patients in the intention to treat analysis, and I think they did a bit of a sensitivity analysis, and I can't imagine that making any significant difference in the final results, but it's nice that they did that. What was interesting was that the Drug Safety Monitoring Board saw an increased risk for bleeding during the pre-specified interim analysis after they enrolled 102 patients in the DOAC arm. And they revised the protocol to start the DOAC when the INR fell below 1.3 as opposed to 2.0 as per the original protocol. The selection of the DOAC was at the discretion of the treating physician, and they were able to deliberately opt for an off-label dose reduction as well, which is more in keeping with what is sometimes done in real life practice. They followed patients for 1, 3, 6, 9, and 12 months with phone interviews. Statistically, they assumed 10 to 15% annual bleed risk with a vitamin K antagonist and expected a relative risk reduction of bleeding by 20 to 30% when switching from vitamin K over to a DOAC for their power calculation. Their primary endpoint was major bleeding or clinically relevant non-major bleeding, defined by the ISHT. I always have difficulties with that one. It's the International Society of Thrombosis and Hemostasis. Secondary endpoints included all-cause mortality, major bleeding, separately from any clinically relevant non-major bleeding complications, which I really liked, as well as clinically relevant non-major bleeding complications, as well as all-cause thromboembolic events, and a composite of ischemic and hemorrhagic strokes. Of note, though, they did stay true to the intention to treat analysis and even included the increased bleeding when patients were switched when their INRs fell below 2. They stratified by renal function between 30 to 50 as well as above 50. As well as thrombosis service, which I'm not exactly clear why they did that, so please let me know in the comments below if you happen to know. In terms of their time in therapeutic range, though, for their INR, it was anywhere between 65 to 74%, which was on average higher than the pivotal trials for atrial fibrillation and DOACs. About 50% of the patients in the switch arm received rivaroxaban, followed by apixaban at 17.4%, then followed by edoxaban at 16.5%, which was a little interesting to me because I would have thought that more patients would be on apixaban than rivaroxaban, at least in my practice setting anyway. There wasn't very much information about dabigatran, but I assume it's because they had like less than 10% of patients who were actually on it, which is more or less in keeping with what I see here in practice. The primary endpoint of major bleeding or clinically relevant non-major bleeding, there was a hazard ratio of 1.69 with a 95% confidence interval of 1.23 to 2.32 with a p-value of 0.0112, which was deemed statistically significant. GI and GU bleeds made up the majority of the bleeds, and there was significantly more in the DOAC group compared to those who stayed with the vitamin K antagonist. The rates of hemorrhagic stroke were fairly similar, about 1%. They did a sensitivity analysis, given that the bleeding curves started to separate about at around 100 days, so about 3 months, and it looks like those who received therapy for more than 100 days had a twofold higher bleeding risk. What was more interesting to me, though, when looking at the subgroup analysis, I know that I probably shouldn't, but I did anyway, was the hazard ratio for the DOACs. Apixaban carried the highest risk, followed by rivaroxaban. Edoxaban, however, did not seem to carry as high of a bleeding risk, and we kind of know that in ENGAGE that there may have been a risk of possibly ineffective therapy with a lower dose of edoxaban, or if the kidney function happened to be really, really good. So this was not too surprising for me, but certainly for apixaban, I was a little bit shocked about. What was also interesting to me was that there was no signal for any difference in age or renal function, as I would think that the older a patient is or the worse their kidney function was, that they would have a higher bleeding risk as well. But again, this too was a subgroup analysis that wasn't powered to detect those types of differences. The secondary exploratory endpoints included all-cause thromboembolic events, a composite of ischemic and hemorrhagic strokes, as well as all-cause mortality, which were all not deemed to be statistically significant, as you would expect, given that this trial was terminated early. In terms of strengths for this trial, they conducted a relatively large trial with a focus not just in elderly patients with atrial fibrillation, but those who were also deemed to be somewhat moderately frail. Elderly frail patients were underrepresented in the four pivotal AF DOAC trials. I also like the fact that they actually used a frailty score. And for those who are not aware, it is the GFI is a 15-point score. A score of 4 and above is considered at least moderately frail, with 15 being the most frail anybody could be according to the index. I do wonder, though, how they decided to use the GFI as opposed to something else like the CGA, which is the Comprehensive Geriatric Assessment Score, which is thought to be sort of like the gold standard and should take like less than 10 minutes to complete. So I'm not sure why, but I'm sure there was probably some practical reason for it. This trial was done pragmatically and allowed physicians to choose the DOACs, which does reflect real world practice. Missing data was relatively low, or so it appeared. In terms of limitations, though, some things to caution. I think we need to be very careful how we think about this trial. Remember that patients included in the trial were already on a vitamin K antagonist. And then they were also followed by a thrombosis clinic service that probably knew them pretty well. And they've probably been monitoring their INRs fairly closely, probably closer than GPs, I would imagine. It is kind of like their one job. I think it's possible that patients who have been on vitamin K antagonists for a while may be used to the nuanced bleeding that can occur and may be less likely to report these types of events in the vitamin K arm. But maybe if they were to be switched over to a DOAC, that they may be more likely to report those types of bleeding if they were switched over to a different drug. I know I probably would if I were a participant in this trial. They did not include patients with a GFR of less than 30, although technically, according to the product monograph and the marketing from Bayer and Bristol Myers Squibb, is that you technically should be able to use these DOACs, just pick the 10A inhibitors anyway, down to a creatinine clearance of about 15 based on their supposed pharmacokinetic data. I am glad, though, that they didn't do this because of what the trial ultimately showed. But if I were to have designed it initially, I probably would have thought about it differently and maybe would have considered that and probably have it backfire. Maybe I shouldn't really call this a bit of a limitation. Next is that not all DOACs are created equal. And we know this from all the observational data that has come out now. So by including all four major DOACs into this trial, I think it can introduce an extra variable and maybe some heterogeneity that we wouldn't otherwise have if we were just to randomize patients to, say, just apixaban. But the way they did this trial being pragmatic in nature, it also could be seen as a strength, I guess. I feel like there should have been a component of patient satisfaction as convenience of DOACs versus having to get blood tests done. I know that in this trial they did home visits, but a lot of the patients where I work don't necessarily get timely home or mobile labs, and often they have to make appointments for their INR testing, and it just becomes really, really cumbersome. And that's the main reason for wanting to use a DOAC and why prescribers prefer to use DOACs. Next is that this trial was stopped early due to futility. And for studies that are truncated, there's always a risk of exaggeration of effect size. So in this trial, there was some crossover action happening, and I'm not exactly sure what happened with the crossover data and how that was accounted for. If anybody happens to know, please let me know in the comments below. Despite being randomized to switching to the DOAC group, 22 patients did not actually switch and ended up staying with their vitamin K antagonist. I'm not sure how they accounted for this data. Did they keep them in the DOAC group or did they add them to the vitamin K group? Given such small numbers, I'm not sure if this would have made a huge difference, but I would like to know. If I read this trial correctly, a total of 51 patients crossed over from the vitamin K to the DOAC group, and a total of 73 patients crossed over the other way around from the DOAC over to the vitamin K antagonist group. Again, I'm not exactly sure how these patients were accounted for. And please let me know if you happen to find out or know. Here's one thing that I just kind of thought of is that this study was conducted between January 2018 and June 2022. In case you've forgotten, we were all part of a global pandemic during this time, where patients may have been put on medications to help treat COVID or may have some, hypercoagulable state, which may have and the drugs that are used to help treat COVID may actually interact with some of the anticoagulants, particularly the DOACs used in this study. And here's this last one. This one may be a little bit over the top, but hear me out. Is it possible that there could be bias the other way around from what we're used to, given that there wasn't any direct industry funding influence? It was funded by the Dutch government as well as unrestricted educational grants from the four manufacturers. Now, given that there are people who are employed at these thrombosis clinics to do the job of monitoring INRs and dosing the vitamin K antagonists accordingly, but by demonstrating that these services are better than using DOACs, it may help to bring more attention and resources to these clinics to help people stay employed. I don't know. It's just a thought, and I'm kind of wrestling with this with my inner thoughts. Maybe I'm overthinking this, but being somebody who works in the public health sector and could easily apply for a position where I could do that and keep a job anticoagulating patients with an INR, and that could be my only job. I don't know. Just something to think about. Now, in terms of generalizability, a lot of my patients who are frail have impaired renal function, and their GFRs or creatinine clearance hovers around the 20 to 40-ish sort of range. So I don't know. It may be difficult to generalize this to my patients for one because of that. The next thing is it's kind of a pharmacy related thing, but the fact that they use an EGFR as opposed to the calculated creatinine clearance may introduce another level of muddiness to the picture. In my practice, I often try to calculate the patient's creatinine clearance to dose the DOACs as per the product monographs. And very often, my elderly patients with low muscle mass or what have you will have a higher GFR than the calculated creatinine clearance. A lot of my patients are already on DOACs, but this trial did not look at those who were already on DOACs and switching to a vitamin K antagonist, rather the other way around. Nor did they randomize newly diagnosed frail elderly patients with atrial fibrillation to just DOAC or vitamin K antagonists. We know from the analyses of the four pivotal DOAC trials that those who were vitamin K antagonist naive tended to do better on DOACs. It would be interesting to see if a study of patients already on DOACs could be randomized to, say, a vitamin K antagonist versus continuing a DOAC. If this trial shows that those who are on DOACs do better on vitamin K antagonists for patients who are not necessarily followed by a thrombosis clinic of some sort, but are followed by family doctors or nurse practitioners with their INR monitoring, that may be closer to a time and therapeutic range of 60%. then maybe I would feel more confident and strongly about recommending patients, frail elderly patients, be put on a vitamin K antagonist. The majority of the patients who are in this trial were Caucasian, and we know that there may be differences in the way that anticoagulants um, may be dosed and metabolized depending on their ethnicity and their enzymes. For example, the standard dose of rivaroxaban in Japan is 15 milligrams as opposed to 20 milligrams, and the reduced Reno dosing is 10 milligrams as opposed to 15. And where I work, there's a much more diverse um, ethnic population than the Dutch population. So we have to always think about that too. In terms of time and therapeutic range, it was higher than those we've seen in the pivotal DOAC trials. One would assume that this could be related to the fact that they were being followed more closely by the thrombosis clinics. So this was not that surprising as a possible reason for why they were seeing that vitamin K antagonist may be associated with a lower bleeding risk than DOACs for this specific population. I have my own issues with time in therapeutic range, though, and that's a whole can of worms that I'm not going to get into for this video. One other thing I found interesting was that patients with higher GFRs, when you looked at the subgroup analysis, actually favored vitamin K antagonists, whereas those with lower GFRs of less than 50, although the confidence interval was fairly wide, leaned towards favoring DOACs, which is very confusing because I would have assumed that those with a lower eGFR would actually do worse on a DOAC for bleeding, which really makes me wonder about those who have a GFR of less than 30 and all the way down to 15. Anyway, those are my thoughts. If you're finding value in this video, please consider giving it a thumbs up, share it with somebody you know, or if you happen to be doing a journal club on this sometime soon, please let me know if you found this video to be helpful in breaking down some of the components of this trial and any ideas that kind of came up. You could consider hitting the notification bell to be notified of any new videos that come out. I try to post about once a week. It really makes a huge difference, especially for such a small channel like mine. I think I have about 60 subscribers now, so I'm kind of inching up slowly and slowly. But what's really, really inspiring for me is when some of you leave comments about how some of these things that I post actually help with your journal club discussions that you have with your staff members. My overall thoughts of this trial is that it's a very thought-provoking one. It really makes me rethink about switching my patients off of warfarin, especially the elderly patients, but not just the elderly patients. It also makes me rethink the cutoff that we're told to use as per our Thrombosis Canada guidelines, and perhaps the INR cutoff of less than 2, which is what thrombosis guidelines will recommend for apixaban and dabigatran, and an INR of 2.5 for rivaroxaban and edoxaban, maybe needs some reevaluation for patients being switched over. And overall, it just makes me much more mindful. I'm actually quite sad, to be honest, that apixaban, that's like my go-to anticoagulant, has been sort of tainted in this trial. And in this subgroup analysis that it revealed similar to possibly higher bleeding risk than rivaroxaban. It's true that these were not randomized nor predefined subgroups, so I have to take them with a grain of salt. But given what we know about rivaroxaban, it sort of did not surprise me that warfarin could have outperformed rivaroxaban. If you're curious to know why, here's a video I made about rivaroxaban and how it's intended to be administered with an evening meal. Again, thank you all for tuning in, and we'll see you in the next one. Say no to drugs.